Okay, okay, so I want to thank you again for joining us. I want to thank my colleagues at the New York City, the New Jersey, and the Delaware chapters for helping us to organize this. And I especially want to thank Tony and Sarah from CMS for joining us. I'm going to go over just a few things, and then I'm going to hand it over to Tony so we can get to the most important things of the evening. I did enable the live transcription. You should be able to see it at the bottom of your screen. If you're not able to see it, at the bottom of your screen, there should be something that says CC or live transcription, and you can click on that to get access to the live transcript. In addition, I assume most of you aren't new to Zoom after the last couple of years, but if you are, you can also click on view, which for me, it's located in the top right-hand corner, and it will change the view from either you'll just see the person speaking, or you can see everyone on the screen. So whatever your preference is there. Just a reminder for everyone to mute themselves while someone else is talking, just because I know that can be distracting and hard for other people to hear. And we will be, after the presentation that Tony and Sarah give, there is going to be an opportunity for question and answer session. So we'll do that a couple of different ways. One option is you can put your questions in the chat. So I really recommend writing down any question you have, like during that you're afraid you'll forget, so that you can type it in the chat when it's time for Q&A. And I can read those out, or if you want to speak, we encourage that as well. And you can raise your hand for a turn to go. And how do you raise your hand? So you can click on reactions at the bottom of your screen. And when you click on reactions, there's a little icon that says raise hand. So I just raised my hand and it put me at the top of the page. So that is how you raise your hand, and we'll call on you. But we're going to start with the presentation. So I'm going to hand it over to Tony, and thank you again, Tony, for doing this with us.
Okay, yeah, thank you very much. And thanks everybody for joining. And my name's Anthony Jamrosi, and I'll put my email in the chat box. I'm the professional relations lead for the New York office of CMS, and basically our states are New York and New Jersey. And you know, I'm when I put my email in the box, I'm opening myself to questions and problems for anybody, because that's part of my job, is to find out how things are going, and to make sure that problems get resolved. I'm here with my colleague, Sarah Bloomstone, and basically the things that we're going to talk about today are both in the final rule for the Medicare physician fee schedule for calendar year 2022. I'm going to talk a little bit about payment rates, and then Sarah is going to cover the permanent expansion of telehealth that was enacted as part of the Consolidated Appropriations Act of 2021. And another thing in the rule is that social workers are now eligible clinicians for the quality payment program. And mostly that will mean that you will be eligible to participate in what's called the merit-based incentive payment system, usually talked about as MIPS. And basically this is a system where it's the only way to, under current legislation, get a raise to your Medicare rates. So let's start off with talking a little bit about the payment rates, because there was a fear at one point that there was going to be a reduction in payments to the tune of like 9 to 10%. And that was based on the fact that the legislation for the COVID public health emergency had increased the Medicare payment rates by 3.75% and had postponed the application of the 2%, what was it called? Sarah, help me out here. The 2% cut, which is sequestration. Okay. And also the American Rescue Plan, the legislation that passed in January, February, added to the federal deficit. And because of that, the Congressional Budget Office was saying that the result on the current legislation would reduce Medicare payments by an additional 4%. So there was a fix in the legislation that passed to raise the debt ceiling. And basically what it did was the 3.75% that was added for the PHE did expire, but they added a 3% increase over the previous payment rates. So that was, like canceled 3% of the 3.75% reduction. It also postponed the sequestration based on the American Rescue Plan for future legislation, and postponed the application of the existing 2% sequestration until April. And in April, it would become 1%. They would start to take back 1% of the Medicare payment. And in July, the full 2% previous sequestration would go into effect. So basically right now, the Medicare rates, were reduced less than 1% over what you've been getting last year. So that's that. And Sarah, you want to take it from here?
Absolutely. Hi, everyone. I'm Sarah. I am a social work intern at the New York office for CMS. And this evening, I'm going to talk about the expansion of telehealth coverage of mental health services that will begin following the termination of the public health emergency, which was recently extended, but these provisions will take effect once that ends. So there are four main kind of provisions that we're going to talk about this evening in terms of telehealth expansion. So that first provision has to do with originating site and geographic limitations. So as a result of the Consolidated Appropriations Act, originating sites of telehealth services for the diagnosis, evaluation, or treatment of mental health disorders is no longer subject to the geographic limitations of the prior Medicare law. So this now means that a patient's home can count as an originating site of telehealth services for the diagnosis, evaluation, and treatment of mental health disorder. And that definition of home under the legislation can include temporary lodging like a hotel, homeless shelter, or a facility in close proximity to a patient's home. In addition to that, rural emergency hospitals are also now permissible as originating sites. The second kind of overarching provision has to do with in-person visit requirements as it relates in part to the home being a patient's originating site. So unless covered by pre-existing provisions of the Medicare law, where this new requirement wouldn't apply, providers of telehealth services must have had an in-person visit with the patient in the 6 months prior to the initiation of telehealth services. So in other words, in order to start telehealth services, there must have been an in-person visit with the client 6 months prior to the initiation of that service. There's another in-person visit requirement where a visit must occur at least every 12 months after a telehealth service is furnished. So there are some exceptions based on beneficiary circumstances for the 12-month in-person visit requirement. However, there are really limited, if any, exceptions to that 6-month in-person visit prior to the telehealth service onset. So the exceptions can include, and so the exceptions for the yearly 12 visit include if the patient and the practitioner agree that the benefits of an in-person non-telehealth service are outweighed by risks and the burdens to the patient or the patient's family. There is some clinician discretion in terms of what those exceptions can be. So if the clinician's professional judgment that the patient is clinically stable or that an in-person visit could risk worsening the condition, creating undue hardship on the patient or the patient's family, or if it's determined that that patient is at risk of sort of disengagement from care that has been effective in the past, these sorts of circumstances could permit sort of foregoing that 12-month in-person visit. It's also possible that as a clinician, you decide that more frequent in-person visits are needed, and that is permitted. It doesn't have to just be one every year. And it's important that any exception to that 12-month in-person visit is noted in the patient's medical record and billing, as CMS is going to monitor those claims to ensure that there isn't overbilling or that there are not drops in quality of care, or to assess the difficulty in accessing in-person care for patients. So there are certain services that were telehealth services that were previously covered in Medicare law that are not subject to these in-person requirements, and that specifically includes opioid treatment programs where a yearly in-person visit is not a requirement. And then looking at rural health facilities of the type mentioned in the prior Medicare law, which were also previously covered, now an in-person non-telehealth appointment must be furnished every 12 months, again with those exceptions based on beneficiary circumstances. So again, if rural health facilities, which were previously covered, if telehealth services are furnished from that originating site, then an in-person visit is required every 12 months after that service is provided. I will briefly mention that in our initial chat, there were some concerns about providers who have given up their office space as a result of the pandemic, and how that will affect sort of in-person visit requirements. And there really isn't anything out there yet about that, but that's an important thing that to kind of keep track of, that we'll be looking for too, to see how those requirements may or may not change as a result of these circumstances where providers no longer have offices or buildings to provide in-person care. There are a couple of other circumstances to consider with these in-person requirements. If an individual presents to an emergency room in psychiatric crisis and the hospital refers them to a psychiatrist or a social worker for services following that hospitalization, that first contact following the referral cannot be done via telehealth. Additionally, if there is, if you are in a group practice with both psychiatrists and social workers. If a social worker sees a patient in person first and refers them out to one of those group psychiatrists, that psychiatrist must also see the patient in person first following that referral. That first visit can't be done via telehealth. However, if the social worker in that scenario is unavailable at a subsequent visit and a different social worker in the group kind of covers that patient, that is fine to be done via telehealth. There is no in-person requirement sort of between similar professionals or professionals of the same sort of degree within the same practice. So now I'm going to transition to coverage of audio-only telehealth services. So as a result of this legislation, they've updated their definition on what they call interactive telecommunication systems. So previously it had to be video, audio, two-way communication to count as telehealth. But now they've expanded their definition to include audio-only telehealth services under specific circumstances. That means that a telephone call without video is now allowed under these conditions, which I'll go into now. So these audio-only services are only covered if the provider is capable of having both audio and visual telehealth services provided. And despite that capability, the patient is unable or unwilling to use audiovisual telehealth services. So in other words, as long as you as the clinician are able to do both audio and a visual or video, but your client doesn't want to go on video for that session or for any sessions, that's allowed so long as you have the capability to do both audio and video. And because of that, there are now special reporting and documentation requirements for this new definition. And that comes in the shape of a modifier that must be used when billing to denote that services were provided using audio-only telehealth communication. And this modifier essentially indicates that you as the clinician were able to do both audio and visual or video, but your client refused or was unable to do that. And then the opioid treatment programs that I had mentioned previously, there's another specific modifier used to denote that those services were provided via audio-only technology as well. And the last big sort of provision has to do with federally qualified health centers and how effective in 2022, as they provide mental health services via telehealth, they will be able to report it and claim it as a full visit, which essentially means that those providers and FQHCs have better payment rates and easier billing processes because of that new provision. And that's all from me.
Tony, it looks like you're still on mute there.
So do we want to take questions on telehealth first? Or do you want to wait till the end, Sam?
That's a good idea. I got a few in the chat. They do want to know what the modifier is for the audio only.
Yeah, Tony, do you know off the top of your head?
Okay, there's a modifier FQ. One other thing that we should mention is that this is the permanent rule that goes into effect after the public health emergency is over. Okay, so like the public health emergency just got extended into April, and basically the all of the waivers still apply. So you report the services that are eligible for audio only telehealth with that modifier 95 right now. There's a new modifier in the HCPCS level 2 system, FQ, okay, that my money is on that one, okay, but the CPT committee just created a modifier 93, okay, for audio only telehealth. So yeah, this is like a wait and see thing right now, but until like April, just report the way you're reporting right now.
And then there's another question. So if social workers refer to a psychiatrist in the same practice, that first psychiatry visit must be in person?
Yes, that's correct.
Okay, and sorry, I'm getting a couple. If a new client wants to start treatment via telehealth, I am unable to do that as I have not seen them, the person in the prior 6 months.
Well, okay, yeah. You want to take that, Sarah? Yeah, basically, the PHE rules are still in effect. So yeah, take this patient, help them.
Okay. Okay, then Deborah asked a good question. So what happens if you saw a patient during the PHE? Do you have to do an in-person 6 months prior to seeing them again on telehealth?
The answer on that one is we don't know. Okay. There's we talk about the things, what's going to happen after the PHE, these waivers. Okay. Right now is under discussion. It's called, we think of it as the cliff. Okay. But, you know, officially it's like a transition. And the rules on the transition are under review. And we don't have anything on that right now. But yeah, by April or, you know, whenever the PHE ends, yeah, we'll have to figure out an answer on this, whether they'll be grandfathered or, you know, whether if you read the law, yeah, they have to, that first telehealth after the PHE ends, if you haven't seen them in person in 6 months, you would have to see them in person before it would be covered.
Okay, and then Keith asks, who can we contact regarding clarification about the exceptions to in-person visits? I am licensed in New Jersey, Illinois, Massachusetts. I have Medicare telehealth clients in Massachusetts and Illinois.
Yeah, I think that's a good question. I think it also would in part kind of relate to the issue where providers no longer have office spaces and the in-person visits. My sort of best guess is that if you kind of go through those exception criteria of like undue burden or risk, that would constitute in theory an exception, as long as it's documented in the medical chart that was the exception or sort of circumstance decided between both the practitioner and the patient. That would seem like a valid exception.
Okay, another question. Thank you both for answering these, by the way. Can a social worker refer to a social worker not in the same practice? The first social worker saw the patient in person. Can the second social worker use only telehealth?
The way it works right now is they, you know, if they're in the same group, that would be okay. But there's limited exceptions. You know, the first social worker is on vacation, and he says, you know, so-and-so is covering for me. You know, there's some questions here where, like, I would like to write them down as, you know, two social workers in independent practice.
Do you want to put your email in the chat again, and then they can
Yeah,
email the?
let's do that. Let's do that. But you know, the other question about the somebody doing telehealth for patients in New York and Massachusetts. That's also a good one that you know, we're going to have to think about. So yeah, let me put my my email in the chat. And
while you're doing that, I'll ask another question, because I think Sarah might be able to answer this. I think you did cover this. When do you change the place of service code for telehealth, and what will it be?
I'm not sure I know the answer, just because I don't have experience with the actual billing and the coding. Tony, do you know?
What the place of service code for telehealth? It's where the patient is. Well, no, hang on. Yeah, that's
When
a
do
good
we
question.
change the place of? Okay, yeah, for telehealth.
Yeah, there's like a list in CPT, and I think telehealth has got its own place of service code. Let me see. Yeah, 02 place of service.
02 place
yeah.
of service.
Yeah.
And what happens if a patient lives far away? What happens to the in-person requirement?
Okay, yeah, that's the same question as the New Jersey, Massachusetts, and yeah, these are good questions, because a lot of them, you know, a lot of telehealth now is, you know, interstate.
Well, and I do have to point out that one thing social workers have to be careful with is that you can only practice in the state you're licensed in unless you have permission from the licensing board, because this does come up a lot. So like if someone's client goes on vacation, they're licensed in New York, the client is in Florida, they cannot see that client in Florida unless they have permission from the licensing board in Florida. So there's licensing rules on top of the Medicaid and Medicare.
Okay, Medicare rules. Okay, that's
okay,
a good point. Yeah.
One, I think you answered this, is the face-to-face within 12 months required now? That's no, it's after the PHE ends, right?
Yeah, right.
Okay. Okay. And then I read the new rules would not go into effect until the year following the end of the PHE. Is that not correct? And to re-clarify, we can continue to see patients via telehealth currently under the PHE without the in-person. Yeah, you already answered that one. So when do the rules go into effect? Oh, Anthony or Tony,
yeah.
You're on.
I'm hunting the law right now, but I think for this face-to-face thing, there's a lot of things like in telehealth, you know, that there's a list of services that are payable under telehealth right now that they want to investigate, and they're going to keep paying for them until the end of the year in which the PHE ends. But as far as I know, this one is when the PHE ends, these rules go into effect. But let me hunt the law, because I have the law in my my files here.
I have a question that's for Sarah. Can we get the definitions for the exceptions, please?
Yeah, I'm going through the law as well to copy and paste directly. So you have that. So I'll post it in the chat momentarily.
And then can you do the in-person in a client's home?
Yes. Yes, of course.
Okay. Are we
Home
using?
visit. Yeah.
Are we using 11 still? With PHE, we were told to use 11. So with the new rules, we use 02.
Well, okay. Telehealth. I mean, do you have an office? 11 is an office, right?
Okay, so 11 is for an office.
If you're in your office doing telehealth, yeah, the place of service is office. But I mean, like if you're at home, you know, it's telehealth, 02. And let me, I have the law up here.
Okay, do you want to read the law?
Yeah. Yeah, I'm hunting it. All right, here we go. Okay. I'm sorry about this. Maybe we, well, I'll write down that question. Okay. And
Yeah.
yeah, let's move on to another question. I'm
Okay.
hunting, but
Yeah,
let's
and
keep talking.
if your question isn't answered, email Tony. He put his email in the chat. Is there an exception for the psychiatrist to have an initial session if the psychiatrist lives out of state?
Okay, an initial initial visit via telehealth, and this is after the pandemic ends.
Okay.
No. Okay, under under the current law, no.
What if we have a home office, as long as we are ADA accessible? Is this an issue?
No, I don't think so.
Okay. I am prepared to go see my clients every so often in Illinois and Massachusetts. However, Medicare tells me I need to submit the claim to the jurisdiction where I am physically at during the session, meaning I could not bill for the Illinois and Massachusetts in-person visit because my Medicare contract is in New Jersey. Would I have to see them pro bono? I am fully licensed in all the states that he practices in.
That's a good question for my email. Okay, I please send it to me by email, because that's, yeah, you know, these
Very
are
specific.
the type of, yeah, these are the type of problems that are going to come up that we're going to have answers for, and I don't have an answer today.
Yeah, and I think too, Tony, we talked about that, like, once you get some of these questions, we can schedule another meeting too, to, like, you know, kind of go over some of the questions coming up. Okay, Florida certifies out-of-state social workers to do telehealth only. How does their certification, which specifically excludes in-person Florida sessions by their certified telehealth agents, coexist with these Medicare rules that contradict them?
Okay, well, you know, like the services are just not covered under Medicare under this, you know, after the PHE ends, these types of services would no longer be covered. Okay, unless there was, you know, some sort of a you know, maybe they were in New York and you saw them. Okay.
This question I can actually answer. Will the rules change in terms of treating patients in another state if we are not licensed in the new location in response to telehealth? NASW, along with CSW and ASWB, is working on an interstate compact. And they have been for over a year. What everyone needs to know is it does take a couple of years to get an interstate compact in place. And then every state has to sign on to the compact. So it'll only count if the state has signed on. I can tell you in New York State has never signed on to a professional interstate compact.
Okay.
So that's to answer that question. Mm-hmm. Can we get a copy of the law?
Yes. In fact, yeah, I'm looking at it right now. Yeah. And
yeah. Okay.
I have the answer to that question actually highlighted, that it's effective on or after the first day after the end of the emergency period described in section 1835 G1B, subject to paragraph B. Okay. So yeah, it's the as soon as the PHENs, the rules from the Consolidated Appropriations Act end. As you know, like all of these rules, you know, like things have changed so much during the pandemic. This is not the only area in which basically clinical practice is totally different from what it used to be, and these you know, rules that apply right now. There's new there's all sorts of legislative proposals that are being considered. So you know, like I would adopt sort of a wait and see approach, but you know, basically what we're telling you is what we have right now.
And Tony, if you want to email me the laws,
Okay.
I can email that out with the recording.
Okay.
So that it'll be accessible.
Yeah. There's highlights in the the text of the law, and those are mine. So just
okay.
yeah.
So everyone heard that.
Yeah.
Can we? Oh, Annie, she's with the Delaware chapter. She asked, can we clarify the point about federally qualified health centers? Is what Sarah said related to the bundling of services?
Okay, basically, yeah, it's the there's like a all-inclusive rate that applies you know, as a either a mental health service or a primary care service. And basically the change was that if they did something by telehealth, they were using a special G code, and they were getting paid at a certain rate. And the change is that they would bill this as a mental health visit now and get paid their standard rate.
Okay. We have a question of how much notice will we get that the PHE is ending? I believe that the president said there'd be a 90-day notice. Is that what you heard as well?
The way it works, you know, like I actually on Monday, I had to ask somebody whether the PHE had ended. Okay. The Secretary of Health and Human Services. Yeah, you want to say something, Sarah? No. Okay. Yeah, the Secretary of Health and Human Services makes a determination, and the determination is effective for 90 days. So what happens is he declared that the PHE still exists on Friday, which is January 14th. And that means that there's a public health emergency until I think it's April 14th or 13th, like this. But yeah, it's extended on you know, at the end of each sort of like extension. And when will it end? You know, I don't think anybody knows right now.
So there is a question that if patients no longer want to come into an office and prefer telehealth, what can we do in relation to billing after the PHE? Like once they have to have that inpatient?
Well, you know, like there's a basic procedure to use if you're going to bill a Medicare patient for a service that you know is not covered under Medicare. And there's something called an advanced beneficiary notice. You know, I could, you know, write me and I'll give you, you know, like links to this. But basically, you advise the patient in writing that this service won't be covered under Medicare, and they agree to pay you directly. And they sign that, okay, advanced beneficiary notice. And if they want the service, they pay you.
Okay.
You submit the claim to Medicare, and it gets denied, and then you bill a patient.
Okay. The PHE is specific. It's a federal. The public health, yeah, that's a federal, not specific to New York.
No, it's the national. Yeah.
Okay. I think I am at the bottom. So I think you can go on to your other part, Tony. And
okay.
and Tony's email is in the chat. So if you have those questions that couldn't be answered, please email him, because that's how he knows how to clarify and what to take to his people.
Yes, and we got some very good questions here. There's, you know, some, yeah, I like to puzzle people, you know, get people worked up. But one of the other things in that final rule for the Medicare physician fee schedule is that for the 2022 performance period, clinical social workers are eligible to participate in the Medicaid merit-based incentive payment system. So I'm going to share my screen because I have a little show for you guys. Okay. So here you see a sort of like an overview of the merit-based prospective payment system. Basically, you get a score between 1 and 100 based on how you do in 4 categories of quality of care. There's metrics on quality, which we'll get into. If you have a certified electronic health record, there's metrics that you could report for that. Okay. Improvement activities. There's about, I think it's 200 activities that you can choose from. And there's a cost category. I'm just giving you an overview of the way the system's set up right now. We're going to get into the details. And basically, most of you, I'd say a large portion of you won't even be eligible for this because there's a threshold that you have to meet in terms of the volume, your Medicare volume, before they'll start looking at the reporting on this. So let me just show you one thing. This is the website that has the total picture of this quality payment program. And it's more than MIPS. There's alternative payment models that you can participate in and maybe get incentive payments to do this. But most of you are going to wind up reporting under this if you qualify. But let me show you where I got here. First, let me point this out. Check your participation status, okay? If you enter your NPI number here and click check status, it will tell you whether you meet the minimum requirements to participate in MIPS. And if you do meet the requirements to participate, whether you participate in a group or as an individual, and whether you have a special status. One of the special statuses is small provider, and a small provider is either an individual or a group with less than 15 members. So, that's one thing that one of the first things that you should do. But what I'm going to talk about, or what I'm going to talk from, is here in the resource library. And these are the 2 things that I have up here as other tabs. So this is the basic overview of the system. And what I want to talk about is whether you qualify. So to qualify for the system, you have to have greater than $90,000 in Medicare billing in a look-back period. And the look-back period, if you click and check your status right now, you're going to see what they've determined based on your billings from July 1st, 2000 through June 30th, 2021. No, July 1st, 2020 to June 30th, 2021. And they'll look to see whether your covered services exceeded $90,000 in allowed charges under Medicare, and you had more than 200 Medicare patients, and you rendered more than 200 services, covered services under Medicare. So if you don't meet all three, you don't have to report at all. That's the good news. The bad news is there's no way for you to get a payment increase in your Medicare rate. So don't disconnect at this point, because let's talk a little bit about the requirements here. And basically what I'm going to give you a wrap is that you could do this. Okay. So first of all, promoting interoperability. I got all sorts of stuff here. These are the rules. If you can, you would report for your certified electronic health record. Okay. For one thing, e-prescribing. Are you in a group with a psychiatrist? And if you are in a group with a psychiatrist, do you have, does the group have more than 15 clinicians in it that are in Medicare? Okay. If not, you're a small provider, and they're not expecting you in 2022 to necessarily have a certified health record. So let's forget about that, right? Then let's go back here. Yeah. Cost. Okay. Cost categories. Cost measures. Okay. There's two global measures: total per capita cost. Okay. You're a primary care doctor, and you know, you're have the lead for care of this patient, and the patient goes into a hospital. Okay. How much does that hospital stay cost the program? Okay. Doesn't apply to social workers. B, Medicare spending per beneficiary clinician. This also is related to medical services and hospital stays. So, boom, doesn't apply to social workers. Look at the rest of these episode-based things here. Okay, none of them apply to you. Okay, so you won't get a cost score. So what happens there is that, let me see, I can't see all my tabs. Here we go, category weights. Yeah. So anyway, what happens here is that usually your score would be based 30% on your quality, 30% on your cost services, 15% on improvement activities, and 25% on your electronic medical record. So we weight two performance categories. You have no electronic medical record. You have no cost. So your quality score is 85% of your total points, and improvement activities are 15% of your total costs. Okay. So let's look at the quality metrics. I got them up here. These are the ones for mental and behavioral health. And, you know, this is another thing, somewhere like after the meeting, I'll share all of these PDFs. Basically what I did here is I chopped pages out of the final rule. So,
perfect.
okay.
Thank
But
you.
here's a listing of the quality metrics that apply to mental and behavioral health. Basically, we get into talking about reporting, and the basic ways of reporting here is claims you can report via your Medicare claims. In other words, you know, you don't have a Medicare health record. You don't want to, you know, make check marks for like every patient that you see over 18 years of age, and document their BMI, whether you documented their BMI or not. Okay. So basically what you're going to do is every time you see a patient, you're going to put a code on your claim that says you checked their BMI. Okay. So that's one way to report. Another way to report is that if you do have a medical a claims, you know, like an electronic health record, and you can, you know, a lot of these, look at these, percentage of patients aged 18 years and older. Okay. Maybe you have a record and you can, you do better on checking BMI for the young people than you do to the older people. Okay. Maybe it's better for you to track that, and in next year, the beginning of next year, you go on this QPP website, and you enter your you know, numerator and denominator. How many patients did you see? How many did you check the BMI for? And it gives a percentage. And then that percentage gets compared to a benchmark, and you score a certain number of points for that quality metric. That's the way this works. The overview is that the performance period for quality is the whole year, you know, January 1st through December 31st of 2022. The performance period for improvement activities, which we get into in a little while, is a 90-day period, a continuous 90-day period within 2022. So these are things where it's there's a certain burden in it, but you know, I think it's doable, and it's a way that you can use to you know, get a raise. And right now, under the way the system works is, here's your performance period 2022. You report in the first 3 months of 2022 for the various metrics. And well, the claims metrics are reported continually. But like if you were going to report through the QPP website, you would report in the first months of 2023. They will tell you how you did, and give you an opportunity to, it's not really an appeal, what they call it's a targeted review. You can say, oh, you know, like, hey, you know, I did more patients than that, or, you know, so like this, and, you know, get a increased score. And then 2024, you get a increase or a decrease depending on how you did on this. Now, there's a certain challenge, okay? The minimum score, where, you know, like, you know, you scored 75 points, you don't have to worry. If you score more than 75 points, you get an increase. If you score less than 75 points, you get a decrease. If you get a 0, the decrease can be 9%. Okay. And, that's, that's something that you want to live with. So this is a thing where, I'm giving you sort of like an overview of this. It's a very complicated system. And there's a logic to it. And once you understand the logic, it becomes a matter of details. But there's a lot of this resource. Let me throw up this website again. Yeah. Help and support. Okay. There's the educational things here, but I just want to point this out. Qpp Support Center. Okay. There's this is 8 a.m. to 8 p.m. I think Eastern time, where you can call them up and ask any questions. And supposedly they'll take simple questions or very complicated situations and tell you how to proceed. There's also, like, they have this email box that they monitor for questions and problems. And of course, there's all these, like, for instance, this is a YouTube video. Let me just cue it up just for fun. Okay. Okay. Yeah. 1 hour and 30 minutes. 1 hour and 30 minutes. Okay. So I think I just killed my yeah, let me do this. Okay. There's also, this doesn't work quite yet, okay? But, you can go into, yeah. There's no performance year 2022 yet, okay? But that's, a work in progress. But, like, I'll give you the list of quality, and then like the quality requirements. Okay. Let me show you an example of a quality metric that I have pulled up already. This is this metric 130. Okay, 130. It's a documentation of medications in the medical record. Okay, and you see this little exclamation point here. When you report on quality, you're supposed to report 6 metrics, and one of them has to be either an outcome measure or a high priority measure. And this says this is a high priority measure. Okay, and what I have here is how you would report this on claims. Okay, and this is another thing where I can send you links for this, because these are Excel files basically, or like zip archives that contain detailed documentation on these. So say you're billing for Medicare, and you're going to say eligible visit during the 12-month payment period. Okay. You submit that using Part B claims, and the denominator, what they say is the denominator. The denominator is it's a Medicare patient 18 years or older. Okay. Okay. And these are the services that you could report for this patient where this this metric would apply. Okay. And what you would do, there's a lot of, you know, like, yeah, you can go into detail on this, but where am I? No. Here you go. Okay. You report performance met. Here's that code that you would put on, you would put that on the claim also, along with the visit code. Medications not documented for medical reasons, you would report this. And current medication, boom, boom, boom. Reason not given, performance not met, boom. Okay. And basically your score on this in terms of would be how many visits did you do? And, you know, this is something that CMS computes. They'll just take it off the claims history. So how many of those applicable visits did you do? And the percentage that you reported, either the performance was met or there was an exception. So what they would do then is they would say with the exceptions and the performance met would give you a percentage of compliance, you know, like success on this metric. And this would be compared to benchmarks based on, you know, the others reporting this metric. And you would get a score, you know, and the score would be at least 6 for this metric. So, you know, basically, this is the way the quality reporting would work. But of course, like that metric, you know, if you could, you have a Medicare, you know, electronic health record, you might be able to report for the whole universe of patients that you treat. And that again is a, you know, a case where you would go in and your QPP, you would sign in, okay, and you could you know, upload your data for that metric as a an alternative to reporting on claims. So let's talk a little bit about improvement activities. And I had some examples for you guys too.
Tony, while you're pulling that up, Carmel asked a question that I think might relieve anxiety for people. She says, if we don't meet eligibility, sorry, I don't know how that word.
Okay, okay.
If we don't meet eligibility.
Those thresholds, the dollar thresholds, yeah.
Yeah, we will not get an incentive payment, but will our fees be negatively impacted?
No, okay. No, that means you're out of the system. And you get no adjustment either up or down.
Okay, that's good to know.
Okay. Now, you know, the way the system works too, it's by a combination of TIN and NPI. So in other words, say, here I am, I have an independent practice and I report under my own tax ID number for my NPI. And then I'm also with a group. Or even more complicated, I work for a hospital and the hospital reports my services under their tax ID number, okay, with my NPI. So, well, okay, yeah. there's you're going to get two different MIPS scores, and you're going to get two different MIPS qualifications. In other words, you might not make $90,000 under the your own tax ID number, but under the hospital's tax ID number, maybe yes. And maybe you do have the 200 Medicare patients, and maybe you do have the, so there's also a special status called hospital-based. I'm talking like, this is the beginning of a conversation here, and I'm assuming people are going to have a lot of questions, and we might have, like pretty regular meetings about this. But, I wanted to give you some of the ideas of, how this could affect you, and, the pros and cons here, okay? But before, and maybe let me just do this one thing with the improvement activities, and then we'll go to questions, because I'm sure there's going to be a lot. So let's see. Here's an improvement activity with a weight of medium. Now, improvement activities. A high activity with a high weight gets 20 points, okay? An activity with a medium weight gets 10 points, okay? And the rule is that you report activities for 40 points. So it could be too high, it could be 4 medium, it could be a high and 2 mediums, okay? And these are 90-day projects, okay? The other thing too I'll mention about improvement activities, if you go in and you check your status and it says you're in a small provider, or you're in a rural area, or you're in a healthcare professional shortage area, then your improvement activity scores are doubled. So in other words, you could get away with 1 high rated activity, 2 medium activities, and meet the requirements. So what I had a favorite one. Okay, let me see. I had it written down. He's 38. Okay. Tracking clinician relationship and responsibility for a patient by reporting macro patient relationship codes. Okay, macro patient relationship codes. Basically, these are a set of 6 modifiers that say whether you have primary responsibility for all of this patient's care, which you never would, okay? Whether you have primary responsibility for a certain portion of the patient's care, whether you're just filling in on a particular patient and providing a incidental care. So basically, if you report those modifiers on 50% of more of your Medicare claims for a minimum of a 90-day continuous payment program, performance period, bing, you're home free. So, and this is just an example. Maybe you don't want to do this, but what I want to point out is that, even if you're like an independent practitioner and you do meet the requirements, it's not the end of the world, okay? That there's an opportunity here for you. And, this is a thing that's doable. So, but let's go to questions. And
thank you, Tony. I just want to say my favorite thing you said was, this is just the starting conversation, and we'll just keep having more of these conversations.
Sure.
I love you giving direct access to the members, because I told you I'm not a clinician. It has to come from them, not me. So
Okay.
I appreciate that. And we do have a couple of questions. Why has Medicare become a secondary insurance to the supplemental insurance?
What's supplemental insurance? Medicare is secondary to like if somebody has if somebody has like a and I don't see how this could affect you, an accident. Okay. And you know, they have workman's compensation or no fault, a situation like that. Medicare is secondary. Medicare is secondary if the person has private coverage under, you know, employment or their spouse's employment. But you know, that's been a part of the Medicare law since wow, I can't remember. You know, like yeah, it's long ago to me.
So it's been a while.
Yeah, yeah.
And then when you were talking about the social worker working in a hospital, and I think also taking private clients. So the question is, in that situation, would the private practice fees go down or up along with the MIPS score of the hospital?
Okay. You know, like one of the strange things, well, I shouldn't say a strange thing about the system, but you'll get 2 scores. You'll get 2 scores as a member of the hospital, and you'll get a score on your, you know, your private reporting. But the way your payment will go will be, you know, based on how you did under either one of them. So in other words, like say, you know, like if you're working for a hospital, generally speaking, the hospital is the one that is getting the score. So, you know, yeah, you know, basically you'll get a score under the hospital, and the hospital is going to get their rate set based on their score, and you'll get your rate set based on your private reporting.
Okay. Then this is not about MIPS. This is a question about clarifying codes. So talking about POS code 02 and POS code 10.
Okay.
So the 02 is the telehealth provided other than in a patient's home, and the 10 is telehealth provided in patient's home. And the question is, could we get clarification on these POS codes and when they come into effect?
Okay, yeah, I'll get clarification on codes for telehealth. Okay, the place of service codes. Yeah, okay. Yeah, I'm looking at, yeah, talk about government. I'm looking at 2021 CPT, and 10 is undefined.
Okay, and I think you had sent me something with the codes before.
Okay, yeah, what I'd sent you previously was, you know, the payment rates for the 5 localities in New York and the 2 localities in New Jersey.
Okay, so
do you want that? Basically, you know, the payment rates, you could go to you know, your contractor's website, and the fee schedules, you just download a whole fee schedule. You know,
yeah,
of course, like social workers are paid at 75% of the physician fees, but you know, I could do this calculation for you if you like again.
Tony, what do we have to do to get that higher?
Get that higher?
Yeah.
I think that's in the law.
How do we change that law?
That's above my pay grade.
Okay, someone said, my understanding is April 1st for Medicare, POS code 10, anyone else? So they're thinking that, so these are the codes they use when they're for telehealth.
Okay, so basically it's the telehealth from the office, from the home. Okay.
Yeah, and what
From the
code they
home.
use and when they start using those codes.
Okay. Okay.
And Deborah said Cigna put out an alert that stated virtual care PSO code 10 in effect April 2022.
Okay. That's Cigna.
Yeah.
Okay. Yeah. You know, like basically, I'll find out. You know, like one of the complications here is okay. There's Medicare Advantage plans like Cigna, and yeah, they cover the same things as Medicare, but you know, their payment rules, you know, like as far as the coding and stuff like that, it's might be different. So what I can do is I can find out what we call original Medicare, which is like the you know, the fee-for-service program, and I can find out what the policy is for that. But you know, yeah, it's let me take this, okay, and get back to you on this because of the fact that you know, like there's HIPAA, administrative simplification, and coding should be national, should be standard.
Okay. And then Miriam put a link in for people. So that, thank you, Miriam, for doing that.
Okay, yeah, thank you.
I don't have any other questions. And I think we have a lot of information to send to people. We'll send the video, we'll send the chat log.
Okay.
We'll send everything you send me, Tony, I'll pass on.
Yeah, I'll send you the law. I'll send you like these PDFs, you know, the PDFs that I had that, you know, I chopped out of the final rule. And you know, there's links. I could send you links, but you know, if you like this, I could send you this nice thing, light reading. Oh, where do you go?
Yeah, really light reading.
Yeah. This resource library. These are
Oh, yes,
here.
Carmel, that would be Carmel,
Yeah.
that'd be great. She's going to send us a resource as well.
Okay. So yeah, there's that.
And then I really appreciate you speaking directly to the clinicians who do this every day. And I love this partnership and want to continue having these workshops. So I'll also pass your email along when we send this out. I have it written on my list. If we get everything tomorrow, I'll send it out tomorrow. If not, it'll be early next week. And then Tony, if you get a lot of questions and you're thinking, hey, let's just have another webinar, you know, let's have another one of these to see if we can clarify some of this stuff, then we'll
Sure.
schedule the
Yeah.
next one.
Yeah, I think like what's going to happen is that there'll be questions focused on a particular area, and maybe we could get the people together and you know, settle everybody's questions in a meeting rather than you know, write a lot of emails.
Yeah, absolutely. If that's what happens, just let me know and we can schedule like another quick one, record it, get it out to our members. And I know they're so appreciative because, you know, they want to be heard. They want for people to
And
hear
we want to hear them. We want to hear
Right.
you guys. So
they're the experts. So
yeah. So and yeah, so okay, so I'll send you the material and links tomorrow, and we'll go from there. And you know, let's see, because people who are not here are going to hear this recording maybe and
yes,
have their own questions. And you know, I'm sure that you know, we'll have follow-up sessions coming out of this.
I think that sounds like a perfect plan. And I just want to thank you too as well, Sarah. You did a great job.
Yeah, thank you, Sarah.
Okay, thank you, everyone. And we'll send this out and we'll just keep meeting until we have more clarification. Have a great night.
Okay, yeah, thanks very much.
Thank you.